Welcome to Endo Strong, where we bring you the expert insights about endometriosis and everything related to endometriosis. I'm your host, Dr. Shilpa, and today we are going to have a very interesting discussion with our guest, Dr. Vivek Salunke, an experienced endometriosis excision surgeon. So, Doctor, welcome to our podcast.
Thank you so much, Shilpa. It is a privilege for me to join your show, and it is important thing to spread awareness about endometriosis. And I really appreciate the work you are doing for the community.
Thank you very much. Thank you very much. Dr. Vivek, first and foremost, to begin with, I would want a small introduction from your side about what you are, what you do, and how did you get into, endometriosis per se as a subject?
Okay, so basically, my training is as a gynecologist. I have had my training in Nair Hospital in Mumbai. Maybe in 97, I passed out from there. Then I practiced obstetrics for 3-4 years. So since last 2003, I have been practicing as an exclusive laparoscopic surgeon. I have left obstetrics since then. Then I got trained in various centers of endometriosis, and last around 15 years, I have been interested in this particular subject, and I got myself trained in advanced surgeries, and I have my most of my work now deals with managing a multidisciplinary team approach to advanced cases of endometriosis.
That's interesting. That's very, very interesting because as we've been focusing on endometriosis and the importance of multidisciplinary team that has to be in place for any endometriosis surgery. So, for common man, can you explain what exactly is endometriosis and how it affects those who have it?
So the endometrium is a inside lining of the uterus, from where it grows, it sheds, and the periods come. So generally, endometrium-like tissue. It's not endometrium, but endometrium-like tissue grows outside the uterus. It could be on the back of the uterus, could be on the supporting ligaments, could be on the ovaries, could be on the various parts away from the pelvis, also in the pelvis and away from the pelvis is endometriosis. So when the normal endometrium bleeds, the blood can come out, but this blood can get trapped. It will cause adhesions. It will cause painful areas in the pelvis. It will attract inflammation and fibrosis, which will cause irritation of the nerves, inflammation, which will cause painful areas in the pelvis and manifest as pain as a symptom. So this is endometriosis, and it affects. It has a grand impact on the day-to-day life of our patients, because it will affect the quality of life, because it will put you on in chronic fatigue, low. You will lose working hours because it's a painful condition. Then it can, because it can cause painful sex. It could cause infertility, marital life can get affected. Even it will cause a social impact on socially and psychologically also. So it's a multifactorial affection of the pelvis. Plus, at times, our patients may be on prolonged medication. That itself adds to their problems.
Right. No, honestly, what you just said exactly tells what endometriosis is all about. The fatigue, which is underplayed by majority of people, is so severe that it can be a task to get off the bed and go for your work or do
Yeah,
your daily day-to-day activities,
yeah, you know your full capacity, but you can't perform because of the physical limitations. So that is not a very uh,
Correct,
good
correct, correct,
feeling.
correct. That's right. That's right. So, what are there any specific symptoms of bowel endometriosis, that because that is something which you specialize in? I mean, you have maximum number of cases for bowel endometriosis, right?
Yeah, it is bowel endometriosis is one of the part which is very scary for the patient too, when they hear that the bowel is involved in endometriosis. endometriosis. So that's what I thought we would have
Correct.
some discussion on this. Generally,
Right.
the patient symptoms for endometriosis are painful periods, pain when the periods are not there, pelvic pain, pain while
Right.
passing to urine and motions, pain going to the legs, and radiating pains to the legs. So
Yes.
when the bowel is on the back of the uterus, the lower part
Mm.
of the bowel is basically a rectum and the sigmoid colon, which is on the
Correct.
back of the uterus. So whenever there is endometriosis on the uterus or on the back of the uterus, supporting ligaments or in the vaginal area, it can penetrate the nearby bowel. So, though endometriosis is not a cancer, but it has some properties in which it behaves like an invasive disease, like a cancer, and it invades. So, bowel basically has three layers. It has the outer serosa, then the muscle, and the inside mucosa. So, it can make a penetration from the serosa to the muscle to the inside mucosa. So, they will always present with some peculiar symptoms, like pain while passing motions is one of the main symptom, constipation, loose stools during periods. So there is some alteration in the normal bowel movements during periods. That is one of the
Right.
symptom which has to
Mhm.
be experienced. And whenever uh, there is a lot of bloating, loose stools during periods, painful motions, or severe constipation, there is a
Mm.
chance that you may have a bowel uh, affection in the deep endometriosis. So
Okay.
endometriosis, which can be superficial and deep. Deep endometriosis generally can penetrate inside the bowel. So these are the particular symptoms which patient could present with.
That gets me to my story where I actually had these symptoms right from the time I remember, and I kept going to the doctors, but like always, I was like said that it is something which I may have like an IBS or something like that.
Yeah, it is
And
many times a diagnosed as IBS. Yes.
yes, so I was treated for IBS for God knows how many years, and until one day I had a blocked intestine.
Oh,
And yeah, so I had a major obstruction in the intestine because of the adhesions that had happened. And that's when my endometriosis was finally diagnosed.
yeah.
So I don't know whether it was a blessing that the intestine had got, blocked, or I don't know what, but at least there was some diagnosis to whatever was happening.
Yeah.
So you just explained the specific symptoms.
Hello. It has gone in mute.
Yeah.
Yeah.
So you just explained to me what can happen in a bowel endometriosis. So what kind of surgical procedures are done for endometriosis, like especially bowel endometriosis, and how does it affect the patient?
Okay, so the bowel getting affected with endometriosis is not very uncommon. Many
Hmm.
times there will be bowel involvement. So actually, all this bowel involvement can be picked up on a pelvic exam, on the sonography, on if required a MRI, and bowel can be affected by endometriosis in various ways. It could go into a superficial layer. It could make the muscle of the bowel thick, or it could make the muscle of the bowel very thick so that the passage of motions gets obstructed. So very rarely a bowel endometriosis patient will present with rectal bleeding, because the mucosa is the innermost part, is the most lately affected. If it is
Okay.
the patient is complaining of rectal bleeding, then it is really a severe bowel endometriosis. Before that, the patient will come with a obstruction. So many times they will present with severe constipation, which is affecting the bowel. So there are three major type of surgeries on bowel. One is when superficial layers are affected. It can be like a shaving or scraping of the disease and taking the sutures on the bowel. That is a shaving procedure. When there is a thickness which increases in the bowel, so you can't shave off a complete thick bowel. So we have to take out a patch of the bowel. That is a disc excision.
Hmm.
So whenever the third scenario, in which the bowel wall is so thick you can't take out a patch, because the circumference of bowel is quite more than 30% affected. or the bowel wall has become very thick, in that you have to take out the affected segment and join the normal part. That is a segmental resection, which is the procedure. So these are the three surgeries on bowel. The imaging, the patient's examination findings, and the imaging will make a help the doctor to make a diagnosis. What procedure exactly patient she will require for her condition. So
Okay.
these are the major surgeries on bowel.
So, what should a patient expect? I mean, obviously, because it's something very new for a patient.
Yeah.
So, what should they expect before, during, and after the surgery?
Okay. The first thing is bowel. Many times when there is a sonography picture or MRI picture of bowel getting affected, there is a panic button which is struck. Patient gets very many times the gynecologist which see the reports, they will scare the patient, or they because of not understanding the disease, they may counsel the patient, which may not be correct, because at times patients think that bowel surgery means having a permanent stomach.
Correct. Correct.
So bowel surgeries, when planned and done, are not very complicated. They can be safely done. If you require a bowel surgery, you have to do it, because that is the only thing which is going to give you relief, and it will give you the progress of the bowel endometriosis will not be there if you treat it that way. And surely the pre-operative symptoms will improve after your surgery. So this shaving procedure and the disc procedure, you don't have lot of changes in the functional outcomes. So what patient is going to experience is the functional outcomes, the type of motions the patient is having prior and later, and what whether this the success of surgery will be judged by that, by the patient. So it is important for us to understand the two procedures, the initial two procedures like a shaving or a disc, are not going to give you a lot of functional outcomes uh, for the patients. The patient's symptoms may improve, and she may not have lot of discomfort after surgery. But the third procedure, which is a segmental resection, may have some changes, more changes in the functional outcome, like the frequency of motions is going to increase. If the resection is very low, then there is something known as lower anterior resection syndrome, where the involuntary passage of stools can come up for some days. The frequency increases. At times, the stenosis, 10% chance it may have a stenosis, so may require more procedures of dilatation. But overall, where the patients who require segmental resection are preoperative symptoms are so uh, disturbing.
Severe. Yeah.
Yeah, so they will definitely get good relief, because they will a patient who is severely constipated person getting a surgery, increase in motions frequency is going to get accepted, right? Because they will
Correct. Obviously.
ease in passing motions. So these are the
Right.
functional outcomes we should expect for bowel surgery.
That's nice because obviously rather than going through the symptoms that you have to go through every day, might as well go for the surgery and just bear with the symptoms for some time, that also is more of a recuperation. You
Yeah.
know you're going to get better.
Yes, yes. You are surely going to get better if the
Yeah.
choice of surgery is proper.
Correct. Correct.
Yes.
It all depends. First of all, it all depends on the surgeon that you're choosing. I
Yeah.
mean, that's
Yes. Yes.
something which I have understood over a period of time because what happens is there are not as many people who are trained to do these surgeries. So there are
Yeah.
people who do incomplete surgeries.
Yeah.
And
I know.
that's the reason why probably people like me have to go for multiple surgeries. So I
Yes.
went
Yes.
through five.
Oh,
So
that
I,
was yes.
it was very bad because surgery after surgery, I was just not getting better. Uh,
Yes.
so that's where my next question comes to. I come to my next question because my first surgery was an open surgery.
Oh,
Okay.
okay.
So because it somehow the it was not possible to do a laparoscopic at that point in time, or the doctor found it not possible. So I wanted to check how feasible is it to do a bowel endometriosis surgery in a minimally invasive way.
Rather, I would say it has to be done in a minimal invasive way, because open surgery is not a correct way to handle deep endometriosis at all. Either you do a laparoscopy, you do a 3D laparoscopy, or you do a robotic. These are the better ways to tackle this issue. Moreover, the scare of bowel surgeries, the complication rates are not as much in the experience centers. Maybe we counsel the complication rate around 2 to 3%. So it's not much. 97% chance you'll nicely get away with it without any problem.
Hmm.
So problem with endometriosis is not like cancer. With cancer, patients will always go, the routine gynecologist will refer them to the oncosurgeons.
Oncologist, right, right.
But this will not happen with deep endometriosis. The routine gynecologists who are not trained in excisional surgeries or not trained in endometriosis will not refer to, they will try to, that's the reason of having multiple surgeries.
Right, right.
And subsequent surgeries become more and more complex.
Correct,
So that is the
correct.
thing.
That's right. That's right. So what are, I mean, to alleviate the fear of surgeries like this, can you educate our audience about what are the potential risks or complications that are associated with bowel surgeries?
Okay, so Shilpa, the bowel surgeries, generally the planning takes place on the imaging. The counseling, everything part takes place prior. So we plan that we have to plan with the patient that you are going to require this bowel surgery. You may require a shaving or you may require a disc. Intraoperative change in plan is possible. So, or you may require a disc resection, or you may require a segment removal. So all this planning is done prior. And basically the surgery on bowel is always scary for routine gynecologists and everyone. So and so the scare is passed on to the patient, because there are the complications which can happen are slightly on the serious note, because
Right.
bowel being a contaminated organ, it can cause a lot of, if it leaks, it can cause a peritonitis, and the action has to be very fast.
Hmm.
What are the potential complications? The suture line which is taken on the bowel can leak.
Hmm.
So it is a leakage in the anastomosis or in the surgical site, and it could at times form abnormal connections with the vagina or the bladder, so it can cause fistulas.
Okay.
Other complication could be resurgery. It can develop pelvic collection after surgery, and you require a resurgery. And at times, if there is a leak, as a protective protection mechanism, you may have to make a stoma. But it is important to understand this stoma is made for the bowel part which is operated to heal. So it is not a permanent stoma. It's there just for 6 to 8 weeks till the primary anastomosis or joining of the bowel heals well, and then it is closed. So even if you require a stoma, unfortunately, you may require it for 6 to 8 weeks. It's not permanent. But
Okay.
these are the complications. So whenever bowel surgery, there is a protocol and ways to monitor it. So you pick up the complications early and act fast.
Hmm.
That is the thing.
Um, I know because so there's this group that I run for endometriosis, and I get a number of calls where people are very scared when the doctor tells them that their bowel involvement is there. So this is like the biggest fear that people have, that would I have to have a stoma for a lifetime? You
Yeah.
know,
Yes.
that's I keep hearing this all the time. And for that matter, even I had this thing in mind before going for my last surgery. I was so scared to go through it, thinking about what if I need a stoma for the rest of my life. you
Yeah.
know because obviously you're young, you don't want to have something like that you
Yeah.
know So, and there is no one to clear those doubts for me. So that's the reason what you said really is something which will help a lot of people. So it's generally for 6 to 8 weeks. It's not there for a lifetime.
But the chances of having it is around 2% or less.
Yeah,
It's
which
not
is like,
much. Yes.
even if you need it, it is just for a time being, not a
Yes. Yes.
permanent thing.
Yeah.
So now, how long does it take for a patient to recover from such a surgery? And are there any specific post-op care that a patient needs?
So when you have a bowel surgery, basically, patient we have patients coming from out of. I practice in Mumbai here in Goregaon. I have a clinic here, and I operate in Lilavati and Hinduja Hospital. These are my workplaces. So
Hmm.
we have patients coming from out of Mumbai. When patients come from out of Mumbai, if bowel involvement, we ask them to be in city for 2 weeks.
Okay. Hmm.
So we generally monitor them for 2 weeks, and complications can come up for 2 weeks, not more than that. And they are in the hospital for 2 or 3 days.
Okay.
Yeah. So bowel patients, surgery patients, had to be monitored closely for 2 weeks. So there are ways to blood test to check required sonographies and test if you
Hmm.
think that there are coming complications. So the
Okay.
recovery is good. We generally put them on stool softeners for a month,
Okay.
and the functional changes in which the patient experience, we tell them around 2 to 3 months it may take for their motions to become normal.
Okay.
So this is a recovery. It has a good recovery.
So do they also have to change their diet? Sorry for interrupting, but do they also have to change their diet or something?
Initially post-op, then once maybe around 2 weeks, they can go on a slightly softer diet,
Okay.
and otherwise there is no long-term. And but then we give them stool softeners.
Hmm. 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 That's understandable. So if if there is any patient who wants to go for endometriosis surgery, is there any recommendation or advice that you would like to give that patient?
Recommendation regarding planning surgery.
Yes, that's right.
So any patient who wants to undergo a deep surgery, deep endometriosis surgery, first you choose your surgeon properly. So in choosing the surgeon, you can see the years of experience, you can see his training, you can see whether he does excision or whether he does ablation. Because excision is the thing is important, because ablation will cause recurrence more of,
Right.
and the disease will not go away. And you can see this whether he practices obstetrics also, because most of the endometriosis surgeons who dedicate their practice to endometriosis will not be able to practice routine gynecology and obstetrics. So this is
Right.
one thing. Then second thing, you see whether there is a multidisciplinary team in place. And so these are the important things. And it is a safely done surgery if it is properly planned. So don't get too much worried about surgery. That would because surgery would be aimed at giving a good relief, and a
That's right.
good excision. The rate of recurrence of deep endo is less than 5%. That's what we tell our patients. Maybe slightly more for adenomyosis and the ovarian disease, which likely to come back more,
Hmm.
maybe around 10 to 12%.
Hmm.
But other deep endometriosis doesn't come back. Even bowel endometriosis, if properly done, properly planned, and correct surgery done, they also don't have very less recurrence chances. They will have very less recurrence. So that
So
would be the advice.
I think most of the recurrences are uh not recurrences per se. They are half done
Yeah, yeah,
endometriosis
yeah.
surgeries, you know?
Residual endometriosis is a big issue for tomorrow. See, residual
Yes,
endometriosis is a big burden. It's going to be a big burden on society, and the training required to resect it is also more. You have to have more excisional surgeons. And in spite of multiple surgeries, the disease, in spite of hysterectomy is done, the oophorectomy is done, you may have a residual disease which needs to be excised.
that's right. That's right. So as it is said, hysterectomy is not an option, not a solution for
Yeah.
endometriosis. We keep emphasizing on this fact. There are adenomyosis, yes, but endometriosis, please, people, that's not the answer. Find the right excision surgeon, and I think half your problems will be solved.
Yes.
So thank you so much, doctor. This session was like really informative for people who are planning their surgery, especially people with bowel endometriosis. I think a lot of their fears would have been alleviated by watching this session.
Yes,
And
yes.
thank
The
you
complications
for,
rate, sorry, the complication rates are not that much, which the rates of,
yeah,
yes, because it's a good chance that you come out of the surgery well.
that's reassuring. That's for sure
Yes.
reassuring. And I'm honestly grateful to you for joining me here for this session. I really wanted to do this with you. And thanks a lot.
Thank you, Shilpa, for having me for your for your session, and it was pleasure for me. So that your our contribution in the part of making awareness about the day-to-day
Absolutely.
disease. Okay.
Absolutely. And to our listeners, thank you for tuning in to EndoStrong. If you have any questions or topics that you would like us to cover in future episodes, feel free to reach out. Until the next time, stay informed and stay healthy. Take care. Bye bye.
Thank you.